promoting the collaboration and translation in R&D.
Sejam
Supporting the
bem-vindos a
increase and
esta
upgrade
segunda
of
sessão da
production
manhã.
capacity.
Esta sessão é dedicada aos
Accelerating the
hospitais enquanto
expansion
utilizadores
of the
finais
health
da
digital
tecnologia
ecosystem,
e, nesse sentido, vamos
implementing
ter agora 3 apresentações sobre a integração das tecnologias no meio hospitalar. Estamos a falar aqui do ponto de vista dos modelos que permitem que isso aconteça e também do ponto de vista da implementação dessas tecnologias e da forma como elas facilitam a adoção de novos modelos de prestação de cuidados. A primeira apresentação desta sessão será sobre o mercado alemão em Digital Health, as suas tendências e oportunidades, nomeadamente sobre o modelo encontrado pelo governo alemão, que entretanto também já está a ser seguido por outras geografias, nomeadamente em França, para promover a utilização e a adoção de soluções tecnológicas de saúde e neste caso estamos a falar do Digital Healthcare Act. Para nos falar sobre esse tema, temos connosco o gestor na área de Digital Health da agência alemã German Trade and Invest, Harold Mylord. Harold tem mais de 20 anos de experiência no mercado alemão da saúde, nomeadamente a ajudar empresas a planear as suas operações na Alemanha. So now switching to English, Harold, I believe you can hear us already?
Yeah.
So thank you so much for accepting our invitation to be here today, and I invite you now to start your presentation.
Yes, hello everybody. Thanks for having me at the Health Cluster Portugal meetings with Health Innovation. My topic today is that I will give an overview about the German digital healthcare market, trends and opportunities. So who's the Germany Trade and Invest? Germany Trade and Invest is the economic development agency of the Federal Republic of Germany. Our shareholder is the Federal Ministry of Economics. We have 2 locations, one in Berlin and one in Bonn. And internationally, Germany Trade and Invest has over 50 locations worldwide, and we are present on all continents with local employees to help German companies, that's the trade part, and foreign companies, this is the invest part, where I'm working in, with their expansion plans. So what do we, what is our portfolio in the invest part? We support potential investors with information about key industries. Today, for example, in healthcare and more specifically in digital health, but we have also other branches within our invest department where I will tell you a little bit later which persons and what topics in the healthcare team are covered. Also, information about key industry usually consists also about market entry informations, for example, certification and reimbursement questions, which are often questions which are of interest to potential investors in the German market. We have a comprehensive portfolio on legal information. So whenever you are having in mind to set up a company, you will need like information how to set a GmbH, that's a legal form of a company, about labor law, taxation is a topic. So these kind of information, we have a comprehensive portfolio we can help you with, and also interesting incentives and financing information. For example, if you are planning to having production facilities in Germany, we can offer financial incentives, but we also have a kind of a lot of R&D schemes and fundings. So these kind of information, where you can get money, how you can get funding, we made available. We also introduce you to local partners. So partnering is a topic, and we also consult you in the site selection process within Germany, because we are responsible for Germany. For the last 2 points, we are working together closely with the regional development agencies. So each German Länder state, we are consisting of about 16 Länder states, has their own regional development agencies, and we are closely working together with them because with partnering, but also with site selection. So if you're looking for office space or for production facilities, but also with recruitment. The regional development agencies know sometimes much better what their regional capacities are. As I mentioned, we are offering this service for different branches and industries. Here you can see our healthcare team. And as you can see, I'm for the specialist in digital health, but we have also specialists in medical devices, in biotechnology, pharmaceuticals, and for example, in medical aids. If you have like questions around these, that would be your contact partners. I will give you my contact details at the end of the presentation. And if it is not like digital health, we still be able to advise and help you and consult you on this. Okay, the German healthcare market. I won't go into the details of these numbers, maybe only one. The total healthcare expenditure in Germany is 470 billion. That is in two aspects interesting, because first, internally within Germany, it's one of the biggest industries we have. 7.5 million people are employed in the healthcare industry, and also externally within Europe, this healthcare expenditure expresses that we are the biggest healthcare market in Europe. So where does all this money come from? Who's going to pay for it? Mainly, it's the health insurance system we have in Germany. As you can say here, we have the statutory health insurance and we have the private health insurance. Both together stands for about 65% of the total healthcare expenditure. As you can see, private households are also paying privately for special things where the health insurance is not paying for, but you can see the main block of the clear majority of the healthcare expenditure is reimbursed by the health insurance company. And we have public health insurances. Where 87% are insured, and we have private health insurance. Just to give you an idea, and the insurance coverage is mandatory in Germany. We are a pretty old population. I didn't know that. I was a little bit surprised of it, but after Japan, we have about 22% of people older than 65. So we are a pretty old population, and that means that, for example, the nursing system, outpatient care or inpatient care, so nursing homes or nursing service providers, is growing because we need to care for more and more elderly people, and this is going to be a problem in the future because nursing, health care will grow, the demand will grow, and we will have problems. So all technologies, all digital applications which help us with that is highly welcome. We have a pretty high number of hospitals compared with other countries, and as you can see, the private hospitals are growing, are rising, while the charity-based and the public hospitals are decreasing. And maybe also interesting, the hospitals with more than 500 beds are increasing. That are usually the private hospitals, and these mid-sized hospitals between 50 and 200 and 200 and 500 beds are decreasing. That reflects that bigger hospitals are better able to produce healthcare quality in specific diseases because the case numbers are higher, the experience is better, and the more mid-sized hospitals cannot reach these healthcare quality numbers as the bigger hospitals. So that's maybe a second structural deficit. And a third structural deficit of our hospital system is that it's a well-known secret that we are a little bit underfinanced over the last 20 years. because the federal states, besides the health insurance companies, are financing the hospitals, their local hospitals, and that has led to to an underfinanced situation, especially in medical equipment. That's why the German government have, at the end of 2020, has set up the Hospital Future Act, and in the Hospital Future Act, there'll be 4.3 billion euro are foreseen to modernize the German hospital system. So it's mainly devoted to modernize emergency capacities on digital infrastructure. What does digital infrastructure mean, or digitalization of the hospital? It mainly means portals for patients, electronic documentation of care and treatment, medication management, and of course, IT security is an important issue because it's sensitive data, and Germany data security is a big issue, and the hospitals need to kind of catch up with the IT security measures and systems there. And that's why some of the money will be devoted to IT security. Also, hospitals will have to spend more on telemedical networks because the basic idea of forms of the last years is a way to connect the hospitals with the physicians, with the nursing homes, with rehabilitation clinics, for example, with the electronic patient record. So on these things, there will have to be spent more money, and so therefore it's a good time for innovative digital health companies, maybe also to get in touch with the German hospitals, to exchange innovative ideas, because the hospitals have to modernize and to digitalize right now considerably. So digital health market, as you can see here, no surprise, the total market in Europe is on the rise. It is predicted to 2026, about 240 billion euro will be the European market, and Germany has quite a bit of it. So 59 billion euro is the German market, so it will be the biggest digital health market in Europe. As I already pointed out, there had been quite a few changes in the last 4 to 5 years, regulatory changes in digital healthcare, and I think the rule breaker was undeniable, the Digital Healthcare Act, which came into force at January 2020. It really represented a systemic opening of the market for digital health applications for 82 million health insured. So these regulations, these laws had opened up the market in 4 main areas. One is the DiGAs, the digital health applications. You may have already heard about it, so that could be medical apps prescribed by a medical doctor. There's a teleconsultation has been strengthened by the new law. The centerpiece of all these digital reforms and healthcare acts have been the electronic health record for every insured person, and also improved access to patient data for research. So that are the main 4 areas. I would like to highlight the first one, because that has really raised attention in Europe. So what are DiGAs? DiGAs are digital health applications, and they have to be a medical product class 1 or 2A, so low risk MDR. Its function has to rely on digital technologies, so it has to be mainly digital, and it has to center around the patient. It is possible to include a doctor, but that should not be the main application. So it should really is oriented towards the patient, and the product functionalities can be, as you can see here, monitoring, treatment, compensation of diseases, injuries, or disabilities. So, and what is the process? I would like to quickly go through the DiGA fast track. So it is possible for a company to hand in a DiGA application And the bear farm, that's the Federal Institute for Drugs and Medical Devices, is going to prove this application. So what are the main requirements? The main requirements are that your application, mostly it is an app, but it could also be a platform, a digital platform, is safety, quality, functionality, privacy, and data security. And there's a second group, I mean, that's the positive care effect. And that's not very trivial. I mean, you have to prove by medical studies that your app has a medical benefits and or improves the structural and procedural improvements. So this has to be proved. That sounds easy, but it all in all, it can consist out of at least 100 different criteria. So only a very few applicants go directly, get an approval to get directly to the listing in the DIGA directory. To be in the DIGA directory is good because you are reimbursed by the health insurance companies. Most of them are not going directly, but they got a preliminary listing in the DIGA directory. That means that you are in the DIGA directory, but only preliminary, and that you have a testing phase of 12 months where you have to kind of show the positive care effects or the requirements you didn't fulfill here. So they give you a kind of and that means the fast track. The fast track is that you're kind of going to it directly, but you can also go in, but after 12 months, you have to prove these positive care effects or these requirements you couldn't prove at the beginning. And after these 12 months, the Federal Institute for Drugs and Medical Devices will decide again, and then you might go into the DIGA directory, or you might be rejected. Well, then you have to kind of sit down again and think your product and your application over and what you can do better. If you are then in the DIGA directory, then price negotiation starts, but this is a different process that would be lead too far here. But this is already a very attractive position if you're on the DIGA directory. So if medical doctors prescribe your app for fear, I just give you some example, for fear, or for sleeplessness, or for migraine, or for psychology therapy, then the health insurance is going to reimburse it. So that's a very attractive way and opened up a totally new market which had not been there before. Okay, that are numbers from the last year. At that time, a total of 89 applications had been handed in. As you can see here, preliminary approved. This preliminary approval is predominant. Only 5 had been continuously approved. So 75% or 1/4 of the applications are going directly. All the others are preliminary. Okay, you had under evaluation that just reflects that this is an ongoing process. New applications are handed in, and others are exiting the market by being rejected or withdrawing their applications. And well, at that time you could see, and that is still the case, cognitive behavioral therapy is predominant, movement therapy, aftercare, and then others. What you can see here, if you look at the top, it's knowledge transfer, so that might be for digital platforms, diary functions, monitoring can be involved, motivation, gamification, training. So that had been the numbers from August. So I think that were 20. Now we have already 32 digital, the DGAs approved, and the numbers are growing. Of course, the process has to improve, and then also the prescriptions have to be improved, because it's not like known by every patient, by every insured person, but the numbers are growing. Well, last but not least, DPAS, DGAS will be the blueprint for enhancing the system. So, as I said, we are very old, the population, and they are planning to enhance, to widen the DGAS to DPAS, to digital care applications. That will be applications which helps us for the healthcare and for the nursing. So this will be enhanced, this approach, and also they are thinking about doing it for digital prevention. What also will help with the distribution of the DGAS will that it will be integrated into the electronic health record, because then every insured has automatically access to what is available as a digital application. And the DGA process might be adopted on the European level. Macron recently announced that they are thinking about introducing same or very similar approach of the certification process for DGAS in France, and behind the scenes it's already discussed to introduce something like that on a European level. So it could be a competitive advantage to know this process and to go through it because it might be introduced on a European level. Okay, teleconsultation. I won't go into the details of all of that because that would lead too far. If anybody is interested in what is going in teleconsultation or electronic health record, please contact Germany Trade and Invest and me, and we will go on from there. The only thing I can say is that the electronic health record is the centerpiece of this digital reforms in the healthcare market in Germany. It is a gradual approach. So in the first years, you just add your personal data, but then you can have an e-recipe. You can have emergency data. You will be able each year it will enhance the opportunities, and everybody will be connected to the electronic health record step by step. So hospitals will be, the physicians will be, and that gives the German healthcare system for the first time the opportunity really to exchange information and not to have them double, triple, or multiple wise in every institution. So that will really kind of is a treasure which can be obtained here. Still at the beginning is the patient data for research. They are setting up a research institution. In a governmental one, who's proving that these data from the healthcare insurances, they're sitting on a mountain of data, but that they will be available anonymously, and they will decide whom to give these data anonymously to work on interesting questions concerning prevention, medication development, epidemiological questions which could be worked on with these data for research. And teleconsultation has experienced quite a boost to COVID. A lot of people are more and more willing to see their doctor by a teleconference, and more things can be done via teleconsultations, and that is growing. And this is an interesting market. So new business business models are evolving there. Okay, this is about my contact details. So if you are planning to set up a business in Germany, please contact us. I will make a meeting with you, and we will discuss your specific problems in detail. But that should be it for the beginning. Thank you very much.
Thank you, Harald, for this very clear presentation on the German ecosystem in digital health. So I will now open the floor to a couple of questions, if there are any. I have a question for you. So, after almost this almost 2 years of the DIGA implementation, so what would you enumerate as the biggest challenges so far? What are the learned lessons that you have taken from this process, and which can help the other European countries, namely other European countries, to implement similar strategies, but even more successfully?
Yeah. Yeah, of course. If you open up a new market and if you are introducing a new certification process, it is always a kind of a new venture in a way, and you are going through a learning curve. The first thing I would say that that it is a challenge to go through this process. It's not that easy as it seems. I mean, for example, for a foreign company to go through the clinical studies where you have to prove the medical value added of your product, that can be very challenging to do it with a German partner. It takes some time, as you have already seen within the certification process. It can needs a time for 3 months proving by the BERFARM, and then if you're not going directly to the directory, it takes another 12 months. So you need time before and maybe another. So it amounts to 1 to 2 years, and it also needs some money because you, of course, with the clinical study, you probably always have your own clinical studies, but you have to do it with a German partner, and you have to show that it is valid. You just can't transfer it one-to-one from what you have done in your home base. So that might be one challenge. But on the other hand, I think it's good that you have to make this certification process because the product has to be safe and it has to kind of have a value added for the patient. So that's okay. Another point would be the marketing. If you are in the DIGA, it doesn't necessarily mean that the physicians in Germany are prescribing your product automatically. So you need a kind of marketing instrument that the DIGAs will be connected to the electronic patient record will help, because then it is obvious what kind of DIGAs are available. So if you have a migraine and look at your electronic patient record, if you look at it, because that has to start as well, then you can see, oh, look, they offer something which might help me, and then you go to your doctor. But that the patients are asking for us will probably, especially at the beginning, will be not the majority. So you need to kind of have innovative distribution channels, like working together with pharmaceutical companies, which are regularly at the general practitioner. So you will also have to find a kind of way to marketing your digital healthcare, your DIGA. And so that are all these kind of things. And also, if you look at the number of prescriptions, that is just starting. So you will go through a process. There's digital health applications are known to the insured, to the patients, and to the general practitioners, and that might last a bit. So I think the biggest hurdle is, to be honest, that it is an attractive way of offering new methods of treating patients, but that it will at least need a few years that you are going through. It will probably not be the case that you are having an app and then sell it million-wise just at the beginning. But it is a good opportunity, and I think it's worthwhile to follow this path.
Thank you. So it does not remove any other steps that are involved in the normal business development in this digital health solution. So it's obviously a channel to improve the way that it gets to the patients, but of course there are still all other challenges that mostly know.
I mean, a good DIGA is a DIGA where the normal healthcare system is not sufficiently able to fulfill the needs. For example, the psychiatrists in Germany, it is very difficult to get a therapy in Germany. You at least need like half a year. So if your DIGA is able to help you or people who are actually suffering in the meantime, then it addresses a real need from patients. So then
Yes.
it maybe also have a quite a huge demand. So DIGA is not like any other DIGA. So there will be there will be very popular ones, and there will be others that might not be having such a amount. So you need to kind of address the needs of the on the consumer, in this case, the patient or the insured.
Thank you, Harold, for this very clear presentation and for these clarifications. So we'll now move to the, sorry, we really have to move now. We have your contact, so if people want to ask any further questions, I will invite them to contact you directly. We're a bit behind schedule, so we'll move to the next presentation. Thank you so much.
Thank you very much. Goodbye.
Bye. Vamos agora então olhar para este tema dos hospitais como utilizadores finais da tecnologia de uma perspectiva um bocadinho diferente. Vamos ouvir falar sobre o papel das tecnologias na promoção da adoção de novos modelos de gestão e prestação de cuidados, e para isso temos Anne Gobel connosco hoje, é a CEO da Prológica, e a quem desde já agradeço ter aceitado o nosso convite. Anne tem mais de 25 anos de experiência em gestão em contextos muito diversos e trabalhando com várias tecnologias. E em 2015 criou aqui uma nova unidade de negócio na Prológica focada em saúde. Esta nova unidade de negócio usa as potencialidades da Business Intelligence e Inteligência Artificial, e a Julquiane também nos vai falar um bocadinho sobre isso. Desde 2018 é embaixadora do Value Based Healthcare Center Europe, e este também é um tema que para o HCP tem sido muito caro e que nós também temos tratado de uma forma particularmente carinhosa. E, portanto, Anne, mais uma vez, obrigada e o palco é teu.
Ok. Boa tarde a todos, ou bom dia a todos. E obrigada ao HCP para me convidar hoje para falar do papel da tecnologia na adoção de novos modelos de gestão. Portanto, o que é que eu vou... Ok. O que é que eu vou tentar fazer hoje, mais do que fazer uma apresentação, é talvez partilhar a nossa experiência. A experiência que nós tivemos nos últimos anos da implementação de plataformas de business intelligence nos hospitais, em Portugal e fora de Portugal, mas precisamente também em Portugal no sector público. Portanto, temos bastante experiência na implementação dessas plataformas. E, portanto, eu vou partilhar essa experiência convosco. Quais são as constatações e o que é que nós podemos fazer, como é que nós podemos utilizar essa tecnologia. Eu penso que é bastante consensual que o problema que existe, os desafios hoje do sector da saúde, não é de certeza a competência dos médicos, dos profissionais de saúde. Nós temos cada vez mais tecnologias em saúde, nós salvamos cada vez mais vidas, e nós temos, com certeza, a capacidade de entregar cuidados com qualidade. O problema para mim, e olhando da nossa experiência dentro dos hospitais, o desafio é gestão, organização e medição. Penso que é o desafio que as organizações de saúde têm hoje. E por quê? Porque essas organizações de saúde, as nossas organizações de saúde, são extremamente complexas. Portanto, o nível de complexidade da atividade de saúde é muito alto. E eu partilho isso porque eu conheço muitos sectores de atividade, não conheço nenhum com esse grau de complexidade. E paradoxalmente, além de ter complexidade, os recursos que são colocados à disposição dessas organizações para fazer face a essa complexidade logística, complexidade no nível da monitorização dos dados econômicos e financeiros, complexidade para gerir os recursos humanos, os recursos que têm não são compatíveis com grande complexidade. Isso é a primeira constatação que nós fazemos. E o core business da saúde, o core business de uma organização de saúde é a entrega de cuidado. A entrega de cuidado de saúde. Isso é a primeira constatação. A segunda constatação é que as nossas organizações estão focadas em entregar quantidade, volume. E não são focadas em entregar valor para os pacientes. Por quê? Porque as organizações não estão preparadas hoje para entregar valor para o paciente, para medir este valor, ter a capacidade de medir este valor. E é muito importante fazer essa medição. E quando estamos a falar de valor, nós estamos sempre, valor em saúde, estamos sempre a falar desta relação entre os resultados em saúde para o paciente, quando comparado com os recursos que são necessários para entregar estes resultados. E isso é o valor. E se nós nos focamos em entregar aos nossos pacientes outcome, resultados em saúde cada vez melhor, nós vamos o fazer de maneira mais eficiente. Não temos dúvida quando nós analisamos... aliás, eu não sei se eu não estou a seguir, desculpa. Isso mesmo. Quando nós nos focamos para entregar valor para os nossos pacientes e fazemos isso de uma maneira repetida, vamos automaticamente o fazer de maneira mais eficiente. Nós vamos analisar a cadeia de entrega de cuidados, nós vamos identificar as ineficiências e vamos eliminar as atividades que não trazem valor para os pacientes. Portanto, a pergunta hoje é como é que nós podemos ter, de facto, uma organização, um sistema de saúde que maximiza o valor entregue ao paciente. Então, essas plataformas de business intelligence e de utilização de dados, é disso que nós estamos a falar hoje, da tecnologia de dados, como que nós podemos a utilizar hoje e qual seria, no fundo, o caminho para fazer essa transformação. Nós estamos todos a falar de transformação digital há muito tempo, mas temos imensa dificuldade a o fazer. E, portanto, acho que tem que partir de uma vontade assertiva de fazer essa transformação e podemos, talvez, pensar a fazer, talvez em uma proposta, a fazer em 2 passos. O primeiro passo é utilizar os dados para perceber o que é que nós estamos a fazer. Com essas plataformas de business intelligence, e não sei bem se todo mundo sabe do que é que eu estou a falar de soluções que agregam os dados de todos os sistemas que existem numa organização, que permitem ter uma visão transversal do percurso do doente dentro da organização, sem ir a cada sistema individual, não é? E que permite depois ter uma camada analítica em cima para analisar devidamente os dados. Portanto, na minha opinião, nós podemos fazer isso em 2 tempos. Primeiro, perceber o que é que nós estamos a fazer. Se nós temos esses dados, nós vamos conseguir monitorizar a produção. Monitorizar toda a nossa atividade, a produção, o contrato de programa. Monitorizar toda a parte econômica e financeira. É muito importante para as organizações. Elas têm que ser sustentáveis. E temos que perceber o que é que estamos a fazer. Também, como todo mundo sabe, hoje, na maior parte dos hospitais, não dispõem de umas soluções de gestão, de uma contabilidade analítica, alguma coisa que em todos os sectores de atividade existe. No sector da saúde, nós não temos isso. Não temos uma contabilidade analítica que permite a cada responsável de serviço, de especialidade, de centro de custo, de perceber quais são os seus custos para essa produção. Será que eu sou, de facto, muito eficiente? Será que eu posso produzir mais? Quais são os custos indiretos que me são atribuídos dentro da minha especialidade? Como é que eu posso gerir a minha atividade? Essa parte do centro de custo, acho que é alguma coisa também de muito importante, e eu tenho um amigo que me diz sempre, mas na saúde ninguém quer saber de custo, todo mundo quer saber de produção. Mas, na realidade, nós vamos ter que começar a perceber quais são os nossos custos. Depois, o percurso do doente. Essas soluções, dentro dos hospitais, permitem identificar o percurso do doente. Elas vão captar as interações que existem com o doente, no seu percurso, e vamos conseguir ver o percurso do doente. E já agora calcular o seu custo. Quanto é que me custa o doente no seu percurso? Só para vos dar um exemplo nós fizemos uma análise do percurso do doente, aliás, em várias instituições, mas eu vou vos dar um exemplo que acho que é muito simples para perceber, que é, nós analisamos o percurso do doente num só procedimento muito fácil, que é cirurgia ambulatória. Nós fizemos a análise dos doentes que foram submetidos a uma cirurgia da hérnia. Portanto, o que não é expectável existir muita variabilidade no percurso de um doente que faz uma cirurgia, está submetido a uma cirurgia da hérnia. Há um percurso típico. Ela entra, tem uma consulta de referência, uma pré-operatória, tem uma cirurgia, tem 2 pós-operatórias, depois vai ver o médico 30 dias depois. Portanto, é um percurso bastante soft dentro da organização. E nós também calculamos o custo deste percurso, em termos de recursos humanos. Quanto tempo? O tempo do cirurgião. Nós fomos buscar os tempos na cirurgia segura. Quanto tempo? Quantos enfermeiros? Quanto tempo dentro da cirurgia? Quantas consultas? E nós começamos a calcular o custo com essas soluções. O que é que nós constatamos? Há uma variabilidade de custo de cerca de 30% num procedimento bastante fácil, com pouca variabilidade, e essa variabilidade não depende das condições iniciais ou do risco associado ao doente. Pronto. Primeira constatação. Segunda constatação nessa área é que, de facto, em termos de percurso do doente, nós tivemos mais de 200 variáveis de 200 percursos diferentes sobre 2.000 pacientes, para um procedimento tão fácil de perceber, tão curto. Portanto, eu diria que o primeiro passo é começar a saber e a perceber o que é que nós fazemos, como que nós podemos optimizar o que é que nós fazemos, e isso nós vamos conseguir fazer só se nós analisamos os dados que nós temos nos sistemas de informação. E todo mundo sabe que os hospitais têm um monte de dados e olham poucos para os seus dados. Okay? Isso o que é que vai permitir criar num primeiro tempo? Vai permitir criar uma cultura data-driven. Vamos permitir aumentar a qualidade dos dados. De facto, quando analisamos os dados, vemos que há muitos dados que faltam. Nós fizemos desenvolvimento de um algoritmo de detecção precoce da sepsis no hospital privado. E o que é que nós constatamos? Há imensos dados que são importantes para poder fazer essa detecção da maneira mais apropriada, mas que não estão no sistema. Ou faltam dados omissos, dados errados. E, portanto, este primeiro step de começar a olhar para os seus dados, não só no nível da administração, do departamento financeiro, do departamento de planeamento e controle, mas também dos profissionais de saúde. Começar a partilhar dados, a olhar para os seus dados é fundamental. Para poder aprender, para poder melhorar e para poder avaliar. A partir do momento onde nós vamos ficar muito mais familiarizados com os nossos dados, onde nós vamos ter muito mais confiança nos dados que estão no sistema, então, a partir desse momento, seria para mim o segundo step, que é, bom, agora nós vamos motivar os profissionais de saúde e há pessoas, porque nós precisamos de uma liderança médica para poder evoluir no sector da saúde, não há dúvida nenhuma. Portanto, motivar os profissionais de saúde em equipas multidisciplinares para poder fazer medição de valor em algumas condições clínicas. E, de preferência, conseguir fazer isso, conseguir fazer projetos multicêntricos, para poder se comparar, porque a competitividade é uma palavra que não se gosta muito de ouvir no sector da saúde, mas a competitividade saudável nos permite evoluir. Nós temos que ter uma abertura para conseguir se comparar, ver o que está feito de melhor aqui no São João, em Coimbra, no Lisboa Central. Nós temos que ver, ok, em condição clínica, fazemos grupos de médicos que podem avaliar, de facto, por condição clínica, o valor para o paciente. E podem o fazer a partir do momento que existe a tecnologia, os dados. Se nós começamos a fazer estudos onde nós temos que ir e introduzir dados, e que nós não temos estes dados automaticamente do sistema, estes movimentos nunca vão ser alavancáveis, não vamos conseguir alavancar. Portanto, sistemas de tratamento, de business intelligence, de dados dentro dos hospitais, utilizados para melhorar a prática médica. Importante também, e o último ponto nessa caminhada para o valor, é que, a partir do momento onde nós temos essas plataformas, que nós estamos familiarizados com os dados, que nós sabemos do que é que nós estamos a falar, nós temos dados muito mais reliáveis. Então, nós vamos também conseguir fazer novos modelos de financiamento na saúde, introduzir novas tecnologias e medir com real-world data os efeitos e os benefícios destes novos tratamentos. Estávamos a falar do DIPA, antes na apresentação, antes de aplicações médicas, que tem que correr quase 1 ano em real-world data para poder comprovar os seus benefícios. Então, mas se os hospitais têm, de facto, essas plataformas, conhecem os seus dados, conseguem, de facto, coletar esses dados e avaliar os benefícios, a segurança dessas novas aplicações, dessas novas tecnologias em saúde. Portanto, acho que é tempo, realmente, é muito importante hoje começar a fazer este caminho, olhar para o que é que nós fazemos e depois criar valor à volta do que é que nós fazemos. Também não temos aqui a palavra incentivo, e outra partilha é que nós temos imensos médicos em vários hospitais que têm as suas bases de dados para poder fazer investigação. Okay? Por que não utilizar essas plataformas, em vez de criar uma base de dados ao lado? Porque nós sabemos também que os dados que nós temos hoje nos sistemas de informação, muitas não são estruturadas. E essas soluções também permitem estruturar os dados para efeito da investigação. Portanto, nós aqui vamos poder criar incentivos e vamos poder criar também parcerias com entidades externas, com as farmacêuticas, por exemplo, para introduzir novas tecnologias. Fundamental começar a abrir, acho eu, a ter uma abertura para a partilha, a transparência dos dados, sempre com o intuito de melhorar os outcomes para o doente, sempre no intuito de melhorar a sua gestão e de optimizar a sua gestão. Eu só tenho mais 3 slides. Eu tinha acabado a minha apresentação, mas depois eu li um artigo este fim de semana sobre as perspectivas da indústria farmacêutica quanto aos estudos de real-world data. Houve um survey que foi feito em 2021 no Brasil, e eles estavam a relatar um pouco, eu acho interessante, o porquê desses estudos para ter standard of care, outcome, para a incorporação de novas tecnologias, é alguma coisa que se faz cada vez mais, mas para isso tem que ter essas plataformas de dados que permitem coletar essa informação. E o desenvolvimento de novos modelos econômicos, estamos a falar de novos modelos de financiamento. Vamos ter que ter financiamentos baseados em outcome, e por isso temos que ser capacitados para recolher os outcomes. Quais são os problemas que eles encontraram nesses estudos no mercado brasileiro? A qualidade dos dados, acho que é em todos os mercados. Dados incompletos, não estruturados, que aqui também podemos remediar a essa situação com plataformas deste. Ausência de regulação, dificuldade de obter aprovação ética para este tipo de estudo, portanto, dentro das organizações. É tudo, acho que é muito o que é que nós também encontramos aqui em Portugal. Última palavra, e porque estamos a falar sempre de tecnologia, estamos sempre a falar de transformação digital, mas não há dúvida nenhuma que essa transformação do sector de saúde vai acontecer, não há dúvida nenhuma, mas é uma transformação que tem uma componente humana muito importante. E, portanto, eu não tenho dúvida que o seu sucesso, o sucesso dessa transformação vai depender também da gestão da mudança. Tem que haver processo de change management. E quando eu falo de change management, eu quero aqui fazer a distinção entre a gestão do projeto, que é uma gestão técnica da mudança, e a gestão das pessoas. As pessoas têm que perceber o porquê dessa transformação. Todo mundo dentro das organizações, não só o top, todo mundo tem que perceber a importância dessa transformação. Tem que, de facto, querer se comprometer com essa transformação, participar a essa transformação. E por isso temos que formar as pessoas. Não há pessoas que vão mudar o seu comportamento e entrar numa zona de desconforto sem ter a formação. Temos que formar os profissionais de saúde para essa transformação. E nós temos que os capacitar depois. Eles podem ter a formação, mas não sabem como a aplicar. Portanto, tudo isso tem que ser pensado. E, por fim, reforçar a mensagem da transformação, para evitar que nós voltamos ao normal. Todo mundo quer sempre voltar ao normal. Reforçar essa mensagem de transformação. change management nessa transformação na saúde é fundamental. Eu já acabei, talvez fui um pouco mais longe, mas é importante essa mensagem que eu queria vos passar. Os dados estão disponíveis dentro das organizações, elas podem ser coletadas e podemos aproveitar para todos mudar, melhorar e transformar o sector da saúde. Muito obrigada.
Muito obrigada a nós, Anne, por esta apresentação cheia de boas ideias para explorar. Nós, de facto, também vamos saltar aqui este Q&A, mas a Anne vai estar aqui o resto do dia connosco, portanto, se tiverem questões, estejam à vontade para as dirigir diretamente à Anne. Nós agora vamos passar, então, para a última apresentação deste painel, sem mais demoras. Vamos ouvir falar sobre Value-Based Healthcare, um caso de estudo em doença cardiovascular, especificamente na área da gestão da estenose aórtica. Como dizia há pouco, este é um tema caro para o HCP e nessa perspectiva convidamos a doutora Marta Cides Carrenho do Hospital Clínico de Barcelona para nos apresentar um estudo de caso, até na perspectiva de podermos vir a expandir algumas das iniciativas que o HCP tem vindo a desenvolver nesta área para outras especialidades médicas. Now switching to English, Marta, thank you so much for being here with us. I think you can hear us.
Hello, how are you?
We're fine, thank you. So thank you very much. Sorry for this slight delay, and I invite you to start your presentation. Thank you.
Thank you very much. Are you seeing my slides?
We are. Yes, we are.
Okay, thank you. Thank you very much for the invitation. And it's my pleasure to share with you our project based on a case based of one disease, a cardiac disease, which is aortic stenosis. For those you are not familiar with, aortic valve stenosis is a progressive disease that is related to the calcification and the regeneration of the aortic valve. And if untreated, it brings us to death. So its prevalence increases with age because mainly it's a degenerative disease related to aging. So it is estimated that now in Europe we have about 2.5 million people with severe aortic stenosis, and this prevalence will increase in the upcoming years because of the aging of our population. Aortic stenosis is diagnosed based on the clinical suspicion of very unspecific symptoms. So indeed, the symptoms it induces is fatigue and shortness of breath, and many elderly people feel that this is normal according to their aging. We can hear a murmur if we use a stethoscope, and it's confirmed with an echocardiogram, a test that it's sometimes lately performed in the course of the disease. So if this disease can be treated very effectively, either with cardiac surgery or with percutaneous approaches, which are less invasive, which we call transcatheter aortic valve implantation. But in those patients who are denied this type of treatments because they are very fragile or they have other severe comorbidities, then we only have palliative treatment. The problems we face currently with aortic stenosis, as in many diseases, is that it's indeed a very unknown disease by the general population. So as I have said, people feel that they are tired and they have shortness of breath because they are just getting old. This is, as I have said, an aging population, so there are a lot of comorbidities in this population. So we have to decide on treating patients with comorbidities, with high risk for these invasive therapies. Sometimes, because they don't know about this disease, they are late diagnosed, and this is a more advanced and more severe disease, so more difficult to treat. Also, patients are many times not included in the decision tree algorithm in the diagnosis and particularly in the choice of the treatment. Also, there is a lot of heterogeneous practice around Europe and around the world, depending on the professional. If you reach a surgeon, you reach a cardiologist. There is no consensus really, despite guidelines treat. There is also a lot of depending strategies to treat these patients, and also there is heterogeneous access to these different therapies around Europe and of course around the world. Mainly, the big problem is that there is a lot of uncoordination among different levels of healthcare and in the social system. So there is no integrated care, and in this, particularly in this disease, this is important because these are, as I have said, elderly patients. So social support is also important for taking care of these patients, particularly if they undergo an intervention. They have to undergo many tests, diagnostic tests, and there's a lot of information they need to integrate. And in the end, there is also no tool to support and facilitate this management, this integrated care. So this is a typical example of what unfortunately happens very often in medicine, which is this type of silos medicine. So there is a lot of fragmented set of healthcare settings and also completely disconnected from the social care services. So the patient goes to one place from the other, and nobody is taking the patient in the center and doing the things around the patient. It's the patient that goes to one place and the other. So in order to overcome all the situation and try to improve this uncoordinated care of aortic stenosis, we started this project, which we call integrative care of aortic stenosis. Our approach was to build a streamlined pathway tailored to the need of each patient by integrating the different levels of care of these patients to provide personalized, faster, and optimized diagnosis and treatment to each of these patients by better coordinating the pathway and the patient's journey along this disease evolution, including the patient on the center and also empowering the patient to participate in the decision making and also on the self-care, potentially with the idea to leading to a more efficient care and also with improved outcomes and potentially lowering the cost of the treatment and the diagnosis and the treatment of these patients. For that, we underwent an internal analysis in our institution and our environment with our referrals. Using Lean methodology, we implemented some system organizational changes and in what we thought were improvements that I will share with you in the following slides. And we try to organize or to orchestrate all this pathway following with digitalization tools, following BPM methodology, business process management methodology. And ideally in the future, we are going to carry out an analysis of transferability to other clinical settings or healthcare settings and also to other diseases. So the first thing that we did was to draw the patient journey in our institution from the very first consultation in the primary care. So when the patient feels bad or goes to the primary care physician because he feels tired, or maybe because he or she feels he has another disease and there is the GP makes an auscultation and hears a murmur, for example. So everything starts there, and then the patient is transferred to a tertiary care institution, typically where he undergoes a first consultation with a general internist or a cardiologist. Then they ask for tests, diagnostic tests. Then it goes back to the consultation. There is here the patient is decided to have the confirmation of the diagnosis of severe aortic stenosis, and then the different options of therapy become available, so the patient can follow different arms. And then, of course, these are patients that need further follow-up. So this is a long journey for the patient. And in each part of this journey, we have limitations that in our area were, for example, the disconnection with the social care in the community, the long waiting lists, the limitations in risk stratification of the comorbidities of that the patient has, and also the limitations in social support, also the different protocols and the different options of therapy that the patients have depending on the different door or the different physicians that the patient might consult. And also for the same thing for the follow-up. Also, of course, we face limited resources as many countries, and also the access to advanced technologies is also limited. To each of these kind of pain points, we try to provide an improvement or a solution that have been implemented progressively at our institution. So the things that we have implemented, and the very first thing is that we built a real hard team. What we call it's a group of different professionals that treat the same patient with different approaches, and we made a consensus and an agreement among them, saying, okay, so we will have this agreement and we will respect this agreement. So saying when the patient comes with this, if these conditions are met, we will do A. If those other conditions are met, we will do B. And in those that are not in any of these groups, we will discuss together. Also, we made an agreement on what would be the minimum information that patients should be required to have when they are transferred or referred from other institutions, trying also to keep in agreement with the other referrals and the other institutions that send patients to our place. The second thing that we built was a single entry point. So make a unique door and entry at the hospital for all our heart-based valve patients, particularly with aortic stenosis. So all the patients refer or coming with aortic stenosis at our institution follow the same circuit and the same pathway. We also work at education of patients in our area. We have a predefined referral area, community area, and also tertiary care referral area in our institution. So we started to work on education for patients to increase awareness of the disease, to make them go for consultation earlier and try to diagnose and treat the disease earlier, and also for our referrals, education on the importance of diagnosing and treating and the possibilities to treat these patients, but also education on how these pathways and these new pathways were going to work and were working. Also, at our hospital, we developed a virtual consultation. So many patients came to us, and we didn't need to wait 1 month to give a consultation, on-site consultation. We could, after following these agreements within the team, we could distribute many patients. Okay, so this patient has these conditions. We have agreed that this patient will be treated with surgery, so we send directly to the cardiac surgeon, or this other patient needs discussion, so we send this to further testing, and we do the discussion with the test already performed. Also, for those patients, we developed this high-resolution consultation. So we had a consultation with a diagnostic test in there, with echocardiography, transesophageal echocardiography, and even exercise echocardiography, and of course, with the possibility of having blood tests on the same consultation, so we could make quick decisions and decide where the patient was going to be sent. So typically, before implementing these measures, we had the patient referred to one cardiologist, then the cardiologist asked for an echocardiography. The echocardiography was performed, then the patient came back to the cardiologist, he saw the results, then he or she decided, okay, we will send him to the surgeon. The surgeon said, no, this patient is not going to be amenable to be operated on because he has high risk, so he should undergo transcatheter procedures. I'm going to send to another cardiologist who's performing the procedure, and then this cardiologist asks for the CT, the coronary angiography, and everything, and then this cardiologist presents in the heart team to decide. So this typically took up to 4 months, and the patient was first seen in the cardiology department until he was the intervention was performed. So with this new approach that we have established, there is one single entry point at the hospital. So there is this virtual consultation. So the first cardiology performs the echocardiography, and then the patient is decided to go directly according to this previous consensus that the group has established. So the patient has already met some criteria for surgery. The patient is already sent to intervention. If the patient has the agreed consensus for TAVI, the patient goes directly for this cardiology with the CT, the coronary everything is performed much more quicker. And in those patients where is debate or there must be some conditions that need to be discussed, then the patient goes to heart team, and this heart team decides if the patient goes for palliative care or not. So typically these 4 months that took up to the intervention has been reduced only to 1 month. So this reduction in the time for decision and the time for intervention is also accompanied, has been also performed with other measures, trying to address other pain points that we detected in our clinical setting, which was this variability or this heterogeneity in clinical practice addressing this patient, the lack that the patient was not involved in the decision, and also our limitations for the follow-up of these patients that sometimes are lost in the system and don't have an adequate follow-up. They are treated, but they are wearing a prosthesis, which also needs follow-up, and sometimes these patients were a little bit lost during follow-up. So to improve this, we involved our referring physicians from other hospitals, from other centers, with a digital support platform that has been, as you know, much improved with the pandemic. So we have connection with the other centers, so they feel much more involved in this new pathway and this new circuit, and they feel part of this heart team. It's not just that they send the patient to the hospital, they feel part of this heart team, and they also participate in the decisions because they are then the ones who know better the patient. And also we have developed an application for our patients where we explain what is the disease. We train them before the intervention, either for surgery or percutaneous approaches, and also for follow-up. And even this is very useful for the patients undergoing palliative care and medical therapy. So they know what's the disease, they know what to do, and also for their care the social support, their family, the relatives they have, that they are also giving support for them. Finally, our next phase is after addressing with these new implementations, addressing these pain points, we plan to develop a digitized tool that coordinates the whole process, because up to now, everything has been working very separately. So we are trying to develop a digitized tool that coordinates all this pathway, and it's helping indeed the physicians and all patients and everybody that the right thing happens at the right time, with task reminders that we have already implemented in the app for the patients, but we need also to implement also in our hospital systems and also in the community, which is further work that we need to work with. Finally, this is absolutely in concordance what the patients are indeed asking us. So patients associations are indeed asking that they need a better integration of the different cares. They need fast pathways to improve the diagnosis and also the treatment of this disease. Also, by simulation, economical simulations, we have estimated that according to some examples in the Netherlands, Germany, France, Italy, and Spain, European countries, we think that this approach is going to be less costly and more effective if this is all accomplished. Finally, we were able to push this approach thanks to some funding from our Catalan government in Spain by different solutions. There are different solutions on how to promote this. The solution that we adopted was a public procurement of innovative solutions. So what we did is, instead of buying only aortic valve prosthesis, which is something that typically hospitals do to provide this therapy to these patients, we bought aortic valve prosthesis with some added value for patients and for professionals. And we did public procurement of all these services that I have been explaining. So we bought some services of patient and referral education, also the service of developing an app, also the outcome monitoring of these patients, which is including PROMs and PREMs, and also the study of cost effectiveness. And also we have included in this formula some risk sharing and outcome-based payment. Finally, when the project is finished in 3 years, we will do an analysis of the scalability of this approach to other areas of our community. This project indeed is being underway and is being developed by 2 companies, which were the ones that won the public procurement, which is Medtronic and also Edward Life Sciences. So they are working together to provide all these services to our institution, where we buy these services thanks to this funding of the Catalan government. So our idea that we will reach after this project will finish is that we will transform the care of aortic stenosis from a typical example of silos medicine to coordination, with the aim of improving the care of our patients and improving the efficiency of our healthcare system. Thank you very much for your attention, and if you have any questions, I will be happy to answer them.
Thank you very much, Marta. I'm not sure you were able to watch the previous presentations, but actually you touched several topics that we were addressing before. So we are now opening the time for a couple of questions before we move to lunchtime. So if there are any questions from the audience, please raise your hand so we can give you the microphone. Okay, so I believe everyone wants to go to the lunchtime now. So thank you so much, Marta. It was a pleasure to have you here and to hear from your experience. Thank you.
Thank you very much. Bye.
Quanto a nós, agradeço-vos mais uma vez a vossa presença nesta primeira parte dos encontros. Voltamos às 14h15 para mais uma parte e uma sessão temática. Obrigada.